Today we are here for a very special session. That is, we have Sir Dr. Kishalay Datta and Sir that who is a HOD Admiral Director of Mass SSB Hospital, Delhi. And what we are Sir will be speaking today is on the topic diabetic emergencies. And Sir has already collabed with our Mediclip 2022. And so yeah, Sir, over to you, Sir.
Hello guys, I'm Dr. Kishalay Datta. I'm the Senior Director and the Head of the Department for Emergency Medicine, Max Healthcare, and also Max Shalimar Bagh Hospital. I'm also the postgraduate teacher for DNB Emergency Medicine. We run DNB Emergency Medicine. Author of several journals like Indian journals, national journals, current journals of emergency medicine. I'm the editor of all these journals, and I do help people with their publications. So I've been asked to talk about diabetic emergencies today. So I'll be discussing about diabetic emergencies today in this forum. So let's begin with diabetes. All of us know that what diabetes is. Diabetes mellitus is. There are type 1 and type 2 diabetes. All of you might be knowing. So today we are more bothered about type 2 diabetes. So type 2 diabetes and its complications. All of us are seeing all through the world and especially in India that it has become, there is a massive prevalence of the disease. Initially, it was in the older populations. Now it has been in the younger populations too. Many young guys around about 25 to 35 are falling to this disease. So we generally say that reasons behind are two. One is dictated by your genes and one is by your lifestyle. So we all know that these are the two major factors which say how you will progress to diabetes mellitus or not. So before that, let's talk about the blood sugar levels, a bit of blood sugar levels before we go into diabetic complications. So nowadays with the newer British guidelines and the American guidelines, we say the patient is diabetic when he has got a fasting blood sugar of more than 126 mg/dl. And American Heart Association says you have got diabetes when a random blood sugar is more than 200 mg/dl. So also you have to know pre-diabetic stage. So any sugar levels between 110, nowadays some say 100 to 126, this criteria, you say it's a pre-diabetic stage. I personally take it between 110 to 126. People who have blood sugar range between this 110 mg/dl to 126 mg/dl are labeled as pre-diabetics, where your interventions like diet, your exercise will help you a lot. And if you focus on your diet and exercise during that pre-diabetic stage, you are bound to come out and become non-diabetic. Otherwise, you may progress to frank diabetes. Now, from the viewpoint of emergency medicine and from the viewpoint of critical care medicine, we will be talking about 4 diabetic complications or emergencies which we face day-to-day life. First emergency is hypoglycemia. Everybody faces. So anyone at your home who is diabetic may have a hypoglycemia, that blood sugar level going below 60 mg/dl. And as you know, a lot of your relatives or friends father, mother, dad suddenly becomes hyperglycemic. Hyperglycemic means anything exceeding 250 and above. So yeah, a relative of yours says today I had a blood sugar of 350. So you measured other things and found nothing. You only saw blood sugar, which is 350 mg/dl. And you labeled him as a hyperglycemic state. So these are the 2 common diabetic emergencies we face in and out daily. So the first one, again, I repeat, is hypoglycemia. And the second one, I repeat, is hyperglycemic state. Third thing, 2 more emergencies you should be knowing. One is called diabetic ketoacidosis, and another is called hyperglycemic, hyperosmolar, non-diabetic state. We all know that. We as doctors, we all know that. So I'll be elaborating slowly on these 4 topics mainly. One is your hypoglycemia, one is your hyperglycemia, one is your DKA, and one is your HHNS. These are the major problems you'll be facing while you'll be working in wards or in the emergencies or in the ICUs. So now coming to hypoglycemia. So whenever you face a patient with hypoglycemia, think of the causes. So first of all, when a patient is brought to your emergency, we make it compulsory for our residents to have the following tests. Any patients coming into your emergency should have a blood sugar or an RBS level measured every time. Let him be fine, let him be non-diabetic, let him be anything. It should be in your protocol that a patient coming to emergency or to ICU or in ward has to have his blood sugar checked. So, and now again, so hypoglycemia, if I say it's less than 60, so you check your RBS and see on the glucometer that it is less than or near about to 60. So do not get confused with a level of 68, 62, 72, 78. Many residents get confused with so many levels. Please have a definitive criteria of 60. Anything less than 60 will level as hypoglycemia. Anything above 60, which is nearing 62. Supposing I come to your emergency and you check my RBS and it's around about 64. So you asked me, sir, when you had your meals, I said I had a fasting of 8 hours. So it might be, if I'm not diabetic, it might be nearer to that level. The best intervention, what you can do is to give him a good carbohydrate food. Just a sandwich or a good fruit juice or a biscuit tea, a sweetened tea or a sweetened curd will be fine and his sugars will be fine. So I find my residents that, sir, when I get a blood sugar level of 64, it's nearing 60, what shall I do? Give him a good meal. Right? But if he has signs and symptoms, then you have to think otherwise. So coming to that, we are coming to that. So now a patient comes to your emergency and or your ward and has a blood sugar level of exactly, say, 60. So you level him as hypoglycemia. So what do you do? So whoever comes to your emergency or whoever comes to your ward, how do you treat? So again, we have here protocolized based treatment. So what we do, every patient coming to ER has to have a set of vitals, an IV line, connect to a monitor, and oxygen unit should be nearby. So these are the basic 4 things what you have to have in your ward or in your emergency or where you are trying to see a patient. So once you are there, take an IV line, and if you see RBS anything less than 60, give him, what do we generally give? We generally give 25% of glucose. That is not correct. Ideally, you should have a 50% of glucose water, glucose D, what we say, and that is the first line of treatment. So in your exams, if you have a question, what is the ideal fluid to be given in an hypoglycemia? It is 50% D water. That is the answer, not 25%. But in majority of the hospitals, what they have a 25% of 100 ml of glucose, which is generally started. And we generally see glucose levels going up and the patient feels okay. So someone who doesn't feel okay after a glucose solution of 25%, the other causes has to be evaluated, why he or she is not feeling well, and also has to be looked at how much of insulin he has taken and how much of glucose you are giving, or shall we maintain with a glucose solution thereafter. All these questions should be coming to your head. Now, simply remembering hypoglycemia, remember the word explain. Explain is EXPLAIN. So this is a mnemonic, you can say. EX is exogenous sources. Exogenous sources is what you give from outside. So the commonest is drugs, mainly your insulin, and now SLG4s, SLG1s, duaglutatides, all those newer drugs of diabetes has come, which may produce an hypoglycemia. So remember like this, if I remember explain, I know the causes of hypoglycemia. EX is exogenous sources. Then P is pituitary diseases. L is liver diseases. A is adrenal crisis or adrenal diseases. Explain. I is insulinoma and N is neuroendocrine diseases. Again, I'll say you should be remember like this. explain EX is exogenous sources. Then P is pituitary diseases. Then L is liver diseases. A is adrenal diseases or adrenal crisis. I is your insulinoma. And N is your neuroendocrine diseases. So if you remember, and you can easily know what are the reasons behind your hypoglycemia, and you can easily answer back, or you can easily find. Majority of the times, you will find the reason to be EX or your insulin. Outside exogenous source of drugs, exogenous drugs, mainly insulin. So be careful. So the basic take home point is, whoever is using insulin or other newer anti-diabetic drugs, you should think of hypoglycemia. This is the commonest emergency, and it can present in various forms. It can mimic stroke, it can mimic altered mental status, it can mimic all other differential diagnoses of yours. So as a doctor, please remember hypoglycemia, please remember exogenous sources, and please remember 50% dewater. So here I'll explain. You can give 25% dextrose also, or glucose also, whatever it comes. There is no harm in giving, but if you have 50% dewater, ideally try to give. Please remember, this glucose is always irritant to your veins. So have a white bone needle and flush it with a lot of saline or a lot of DNS solutions. So the first emergency is hypoglycemia. So hyperglycemia, you have a lot of causes. Every cause in a diabetic patient can produce hyperglycemia. The commonest are patient not following their drug treatment. So supposing I am a diabetic patient, I have been advised by you to be on insulin and some drugs. So what I do not take your drugs on a regular basis. I follow my own principles. I follow my own lifestyles. I go to a lot of other non-medical persons for my treatment. And I have an hyperglycemic state long term. Many patients also have difficulty initially when you say them that you are diabetic. It's very difficult to initially admit that I'm having a disease of diabetes. They will just say, why did I have diabetes? My father did not have, my sister did not have, my mother did not have. You are saying I'm having diabetes. The next thing what happens is, when you say diabetes, you cut down on his food. Yeah. Please remember, food gives you a pleasant sensation, and when you cut down on someone's food, he or she will have difficulty in accepting it, especially people like me who have sweet tooth. So if you cut down on the sugars, people who have fascinations for cold drinks, good food, good sugars, good sugary foods will have difficulty in accepting that I am diabetes. A lot of other diseases can also produce hyperglycemic state, as I mentioned. A lot of your liver diseases can, your pancreatitis can, your malignancies can, and a lot of other diseases. So whenever you get an hyperglycemic state, as a doctor, you should advise or ask him what you wear, on what drugs you wear, and tell him either to consult a doctor as a primary physician, or tell him that you have to follow your medications. If you're fit, add up a bit of exercise and cut down on your diet. So in hyperglycemic states, though it's not as dangerous as hypoglycemic states, but still you have, as a doctor, you have to give advice that please be careful, because if you are constantly allowing hyperglycemic state, you will have a lot of macro and microvascular complications, the common being heart attacks and strokes. So you have to warn them of those things. Now coming to two more major complications, which we as doctors deal every day, as emergency doctors or critical care units deal every day in and out, or yourself being a ward doctor are faced. What should I do? What should I do? So the two emergencies now I'll talk is, one is diabetic ketoacidosis, another is HHNS. So now first coming to diabetic ketoacidosis. The name itself is DKA. So D means, if you look at the name, D means diabetes. So remember, anything more than 250 will be needed to say a person is diabetes. Then K is ketosis or ketone bodies in urine or blood, and A is acidosis. So these are the three things which must be present. The word is must be present. Sugar should be more than 250, ketone should be present, acidosis should be present. If any one of them is absent, it is not decay. Please remember this. If you go to outside this country to practice, the first criteria is sugars more than 250. You have to have ketone bodies and acidosis. Now a fourth criteria has also been added, that is bicarbonate, which should be less than 15 milliequivalents per liter. So you have four criteria. If these four criteria are not present, you cannot label him as a diabetic ketoacidosis. Nowadays, in diabetic ketoacidosis, there is also a condition called euglycemic ketoacidosis, where the sugars are normal and still you have ketoacidosis. So again, I say this criteria should be met to have someone labeled as diabetes ketoacidosis. So again, DS sugars more than 250. Ketones. Now, coming to ketones, you have an urine dipstick. You can take an urine of the patient, take the dipstick and compare it to the body of that dipstick where it shows the different colors, and you can see ketones positive. So here I have two things to say. The primary ketones in your body are acetone, acetoacetic acid, and beta-hydroxybutyric acid. All of us know that. Your levels are 0.3 millimoles per liter, normal levels. So, and ketones are highly acidotic. Acids, ketones are acids, so they will produce acidosis. That's why the name has come ketoacidosis. Clear? So what you do when you measure with that dipstick, the dipstick measures acetoacetic acid or acetone. These are the two things. It does not measure beta-hydroxybutyric acid. That's why majority of your dipsticks will be negative. Understood? So send ketones for blood ketones always. Whenever you do dipstick urine, also send ketones, blood ketones too. And acidosis, the only way to pick up acidosis is you have to do an ABG. In ABG, you have four criteria: pH, PaCO2, PaO2, and bicarbonate. So all other parameters can be easily located. So coming to the diagnosis, come from the name of decay, look diabetes, look ketoacidosis, both urine and look acidosis individually via the pH. And you can also have a look at your bicarbonate. So diagnosis is clear, it's easy if you come from the name. And conditions which produce. So you are a diabetic, please remember 5 conditions. These 5 conditions has to be remembered. Rest of the things you might remember, you may not remember, but these things generally produce decays. So first thing is a stroke. In a diabetic, if you have a stroke, you have a high tendency to go into ketoacidosis. Anemia will also produce diabetic ketoacidosis. And third is infection. Whenever you think of infection, think of 3 things: necklines, chest, abdomen, and genitourinary. These are the 3 to 4 things you have to think. Central lines, dialysis catheter, central line, other lines, chest infections, pneumonia or any other infections, abdominal infections, and genitourinary. So these are the 3 causes, main 3 causes. What you will get: one is MI, one is stroke, and one is infection. 2 more things you have to know. One is pregnancy, if you are pregnant, and another is trauma. I generally tell my residents to remember these 5 causes, and if you are able to remember, you can remember other causes. The same 5 causes are responsible for your HHNS also. Please remember this. So you do not have to remember separate causes for HHNS. You have to remember the same causes of decay produces HHNS. Now coming to treatment of decay. So if you go via the British Association or British Society, initial treatment is start him on fluids. So what we do, we take 2 IV lines and start him on normal saline. Normal saline you have, start him. Please remember, a decay patient will be 5 to 6 liters dehydrated. Simple, remember 5 to 6 liters मेरे को रिप्लेनिश करना है, 1-2 लीटर जल्दी देना है, और उसके बाद धीरे धीरे 6-8 घंटा 10 घंटा 12 घंटा में पाके हम रिप्लेनिश करेंगे. So you will not overload the system, provided if he is not in CKD or in acute AKI, right? So what we do generally, we start, give 1 liter stat. 1 liter stat means 1 liter over 30 minutes. Give another 1 liter over 1 hour. So 2 liters has gone. Then slowly we go liter in 4 hours, in 3 hours करके हम 5 से 6 लीटर अंदर देते हैं. साथ साथ में हम इंसुलिन चालू करते हैं. So people have a lot of problem with insulin, how to start insulin, what to start insulin, what to not start insulin. So if you go to the market, you will have several types of insulin. The commonest insulin we use is regular insulin, or which is available insulin, right? So how to use that insulin? So all of you might have heard of sliding scales, infusion scales. So these scales, please remember, these scales are not in your books. These scales are made by you. The first thing, so what we do, we make the scales according to our convenience, and then we make a chart like that. More than 400, inform the medical officer. 350 to 400, give 10 units. This is the common chart. This is the chart which will give you very poor control of your sugars. So if you are a good doctor, I'll never advise you to use this chart. So make a chart with a difference of 25 to 30 milligrams of sugar and 0.5 units variation. So for our units, we have a separate chart. We have made a chart, 3 charts, and we give it to our students, and they see the chart, and accordingly they start the insulin. So insulin, how to start an insulin? All of you have seen a syringe pump. All of you have seen a 50 ml syringe. So it's very easy. The concept is you take 50 ml of normal saline and give 50 units of insulin in it. So what does it become? 1 unit of insulin becomes 1 ml. Clear?
Yes.
50 units of insulin plus 50 ml of normal saline. So 1 ml equal to 1 unit. This, yeah, clear? Yes. So we do this, and then we start 6 to 7 units at the initial starting, and slowly every hour we measure the RBS, and every hour we increase or decrease the dose of insulin. Here, 1 or 2 things what you'll face is, if you are treating patients, if sugars are going low, you see in many patients, as you start insulin, sugar tends to fall. So if sugar is approaching 110, 120, and if still ketones are there, then you have to give dextrosaline, so that your sugars does not go below 110. That is what we generally do. So these are the 2 measures. You give a lot of fluids, you give insulin, and measure every hour until it becomes normal. What is your target? Till what time do you continue insulin? Until you check every time and see there is no ketones in blood or urine. So it will take you to 12 to 14 hours before the ketones generally go off. And by that time, the patient will improve. Yes. So the third point is, when you give insulin, a lot of your potassium will move intracellularly. Insulin as a role, it pushes your potassium into the cells. So what we do, if starting insulin, the potassium levels we measure regularly 4 hourly or 6 hourly, and if we see potassium going down, we give a potassium correction tool. So these are the 3 basic lines we do. One is IV fluid, one is insulin, and correction of potassium. Other treatments for causes like he had a stroke, he had an MI, those things should be done as per the standard protocol. Infection, antibiotics, other things, whatever is needed has to be done. So continue with the other treatment for the cause, and continue these 3 things: insulin, IV fluids, insulin, and potassium. There are several questions like, shall I use a bicarbonate if the pH goes below 7.1 or 7.2? Ideally, the standard textbooks say do not use bicarbonate. But if you have the patient is collapsing in front of you, so follow your ACLS protocol, because bicarbonate does not help to get you out of acidosis. It might help, but there is a thing called dissociation constant. Depending on the dissociation constant of carbonic acid, we have to give bicarbonate at a last resort. Ideally, we should not give, right? So coming to the fourth complication, which is important, is HHNS. HHNS is hyperglycemic, hyperosmolar, non-ketotic state. So what, again from the name, what we find? Hyperglycemic. So hyperglycemic, H is sugars more than 400, 450. In an glucometer, what we regularly use, your glucometer generally shows high. Instead of showing a number, it shows high. So whenever your glucometer shows high, be careful of, think of HHNS. The next thing is, H is hyperosmolar, N is non-ketotic state. So ideally we should not find ketones, but occasionally we can have ketones. Now coming to, so your diagnosis depends from the name only. And then, as I have told you in decay, there are 5 major causes. 3 causes, all of you know: infection, CVA and MI. 2 more causes, trauma and pregnancy. Rest, you'll have a lot of causes. And please remember here one thing, HHNS is seen in elderly, not seen in young people. So when you are treating elderly patients, please remember, though they are dehydrated, their fluid should not be corrected at a rapid pace. So ideally, they are also severely dehydrated. But what we do here, the treatment, we have 3 parts here again also. So we correct with fluids, we correct with insulin, and HHNS is predisposing to hypercoagulable state. So we need to give here low molecular weight heparins. So that they do not have a DVT or a pulmonary embolism later on. So here we start insulin, we start with fluids. Here be judicious with your fluids, give 1 liter every 4 hours or 6 hours. Supplement, but do not rush it. Then go with insulin, as I have told, 50 mg plus 50 units. Go start with 6 units. You don't need a bolus of insulin these days. And continuously monitor RBS every hour and tally your insulin accordingly. And finally, give them a shot of low molecular weight heparins or unfractionated heparins so that they do not go into thromboembolic phases. Thank you. These were the 4 major emergencies. Again, I repeat: hypoglycemia, hyperglycemic state, diabetic ketoacidosis, and hyperglycemic, hyperosmolar, non-ketotic state. Thank you.
Okay, sir. We have some questions here. And sir, the first question what I have is, so what is the cause for pale and the clammy skin? Clammy skin usually is sweaty skin in case of diabetic emergency.
As you know, the patient is severely dehydrated. Your cardiac output has been decreased, and the body is trying to conserve all its perfusion to the major organs. So this is the major reason why you have a wet, cool, and clammy skin.
Okay, sir. Thank you, sir. And so next what we have is why we should not give oral glucose in an unconscious patient with hyperglycemia.
So first of all, 2 things you should be thinking in your head. In a patient who is unconscious, please remember he or she is not able to have a control of his or her airway. So if you try to put sugar inside him, it might go to his lungs. One risk is aspiration. Second thing, why is unconscious? You don't know. So the GI absorption of sugar will be poor. So if you have a poor GI absorption of sugar, your blood sugar will not raise immediately. So it's always better to put sugars in your IV, in your drainage system or pump system.
Okay. So next what we have is, suppose a patient is then got diabetes and is controlled with medication. Now, sir, if he has an infection, so will it lead to a diabetic emergency? Will an infection lead to diabetic emergency?
So here there are a lot of questions which you have to remember. A lot of things you have to remember. So supposing I am a diabetic, I get a cough or a simple URTI, I may not go into a decay. But the standard teaching is, in all diabetics, you have to be careful how his infection flares up. and how his sugar behaves. There is no hard and fast rule that you have an UTI and you'll go into a diabetic ketoacidosis, or you have a pneumonia and 100% guaranteed you will go into a diabetic ketoacidosis. This is how you check every other time, how you see your sugar levels, how you maintain, and it depends on all these factors taken together.
Okay. So next what we have is why do diabetic patients develop hypoglycemia although they have enough glycogen in their livers?
So see, so when you have diabetes, you take a lot of food, you have your gluconeogenesis and glycogenolysis. All these are going in your liver, but liver itself becomes resistant to your insulin. So there is a term called insulin resistance. So without insulin or insulin resistance, the liver becomes resistant to all these functions. And secondly, insulin helps to store your sugars in your skeletal muscles. That is also insulin dependent. So if you have an insulin resistant, those processes will not work. And so you have a tendency to have all these problems. So it is mainly insulin resistance.
Okay, so thank you, sir, for all the questions. So one more question which we have is a real legit question from our follower. The question is, sir, can you guide us for regarding the emergency medicine courses? Because in the market, what we have is
so,
MEM or MRCM is less. So it is worth it or not?
So I'll discuss about it in a bit right now. So see, I came from a background of emergency medicine in 2003. I came from a background of internal medicine. So I had a degree, postgraduate degree in internal medicine. Then I went to UK, did my MRCPs and did a lot of things. And then I used to practice. I passed in the 90s and I used to have a good practice of internal medicine. In 2003, I, along with my friends, went to Kerala to start a thing called IIAMS. So it was an emergency medical service, and it was more based on ambulance. So many people considered me as a pioneer of emergency medicine in India, but that's nothing. So what I did after that, I got into emergency medicine to study what was being taught into emergency medicine, and I became a student to learn emergency medicine. I went to UK, and then I went again to US. I went to Alfred in the Melbourne, Australia. I went many places to have an idea what was emergency medicine. So as I got an idea of emergency medicine, I, along with my friends, started doing a lot of work to ask the government of India to recognize emergency medicine as a specialty. In other countries, it was recognized in 1976 and before. In our country, we were able to recognize it by the government of India in 2009. I was one of the members who was there during the recognition time. Then I was after the government body, and I was going on, and I was the first guy who got DNB emergency medicine in 2014. So I started emergency medicine DNB 2014 with 3 students and with primary and secondary seats. Now, before that, I also was involved in training people in order to make a good supply of manpower. I also trained a lot of people who were doing their masters in emergency medicine. So that was called MEM. It was initially called Fellowship of Emergency Medicine for 3 years. It was initially 2 years, became 3 years, and it name changed into Masters of Emergency Medicine, what you call MEM. So what is good about MEM is the course which George Washington University held, because they are pioneers in emergency medicine all over the world, GW. George Washington University. They helped us, or the Indians, to set up a course or a course structure on which emergency medicine training will progress. So they helped us in setting up these 3-year fellowships. Based on this, our DNB started. Based on this GW MEM course, it started. But the problem with the GW MEM course is it's not recognized. It's not recognized by government of India. That is the problem with the course. But as a course, if you want my opinion, it's a good course, because it teaches, if you do it from a good place, it teaches you a lot of things, right? And you become trained as an emergency physician. So the next thing is MRChem or MRChem. So that is an additional qualification recognized or given by the government of India, but it's an UK postgraduate degree. So you cannot take any country's postgraduate degree very lightly. they are giving it as their postgraduate degree, right? So
Yes.
what is the minimum criteria? You can appear the steps A and B without experience, but in emergency medicine. But if you sit for the practicals of MRChem, you have to have an 18 or 1.5 years of training in emergency medicine. So they have kept it there. So if you are going for OSCE, you have to have 1.5 years of training. I personally find if someone has to do MRChem, he can do an MRChem, which is, he can do an MEM, which gives him a 3 years residency program.
Experience.
And in that, while doing that, he can also clear his MRChem. So that will give him 3 years of training in emergency medicine, along with a degree of MRChem, by which he can go to UK or Commonwealth countries or Australia. He can have a GMC registration and work there. This is an alternative pathway. If you are very good, you can always go for DNBs or MDs in emergency medicine. But everybody is not that good. So it is an alternate pathway by which people can go to UK, do an FRChem, which is recognized by NMC. FRChem, the same part A and part B exams will be given in UK after training, after 1.5 years, and you can get an FRChem degree, which is recognized by NMC. So you have a pathway by which you can get yourself recognized. So don't think much about recognition. I personally believe you should not think much of recognition. If you are into emergency medicine, do an MEM or an MRChem, go to UK, do an FRChem, get yourself recognized. You're good enough. You are already into the alternative pathway. You haven't cleared your NEET PG. So why are you thinking so much? I have not cleared my NEET PG. I need to find an alternate way to go to the top. So if I want to go to the top, I have to do an MRChem, I have to do an FRChem. Simple as that.
Yes. Okay, sir. Then
it's nothing like MD versus. For me, see, my DNB students all are doing FRChem. They have to do. So these are my students are given the opinion that DNB you have a recognized degree, you can work in India, but with the DNB you cannot work in UK. So do your MRChem and FRChem. So they are forced to do double degrees, and in this 3 years time only. So I have made it compulsory for my students to do it. No alternatives.
Sir, so yeah, thank you, sir. Thank you so much for your time, and thank you so much, sir.
Thank you.